Hello everyone, this is Dr. Vaibhav. So this is the last part of the series for adults lines and tubes. Today we will be discussing cardiovascular related lines and tubes. I was just going through the previous sessions, examiner's recommendation for FRCR 2B exam, and there it was mentioned that candidates should have some knowledge about cardiovascular related lines and tubes. And because of that, I thought let's conduct one session for on the same topic. Okay, so the first and foremost thing that should come to our mind is central venous catheter. So uses of central venous catheter is for IV fluids delivery, drugs delivery, for chemotherapy agents, also for total parenteral nutrition, for hemodialysis monitoring, also for hemodynamic monitoring, also for hemodialysis and plasmapheresis. What is the course of the catheter? It is inserted, most commonly inserted via interjugular vein. Then it goes via subclavian, can be inserted via subclavian vein or femoral vein. It passes through the major veins into brachiocephalic vein, and then the tip should ideally lie between the junction of SVC and right atrium. Like we have discussed, that is the ideal tip position. What if it is malposition? If it is too high, then it will give you inaccurate readings for central venous pressure. Uh, then there will be poor drug delivery. If it is into the right atrium, then there are high chances that patient might develop arrhythmias, risk of perforations. If into the other veins such as azygous vein or contralateral veins, that will cause ineffective function of the central venous catheter. If there is associated extravasation because of the vascular injury, then there will be surrounding hemorrhage formation, tissue damage, and complications such as mediastinal leak or pleural effusion. This is how the line will appear on the chest radiograph. Now coming to the second catheter, which is Swan-Ganz catheter. Basically, the most important use is to measure pulmonary artery pressure. Also, it is used to estimate what is the left atrial pressure, which is indirect indicator of pulmonary artery pressure. Then assesses cardiac output and hemodynamics, also used in shocks, heart failures, and critical care monitoring. What is the course of the catheter? Ideally inserted via central vein, either interjugular vein or subclavian vein. Then it passes into SVC, then right atrium, right ventricle, and then into pulmonary artery. Like this. This is right atrium, right ventricle through the pulmonary valve into one of the proximal portion of the segmental branches of the pulmonary artery. So ideal tip position is in the main pulmonary artery or proximal portion of right or left pulmonary artery, not too distal, because it will again cause then wedging that will give you false or inaccurate readings of pulmonary artery pressure. What if it is malposition? If the tip lies into the right ventricle, then there are chances of arrhythmias. If it is too distal, that will cause inaccurate reading, pulmonary infarction, and might be damage to the segmental pulmonary arteries. If it is coiled or kinked, then it will give you inaccurate pressure readings. If it is outside the vessel, then that will cause lung injury and associated hemothorax or pleural effusion. The next that you should be knowing and how it looks like on chest radiograph is intra-aortic balloon pump, which is frequently known as IABP. The uses of the IABP is in cardiogenic shock. It supports in severe left ventricular failure to maintain the cardiac output. Bridge to definitive therapy before getting the patient for PCI, CABG, or for heart transplant. And also, this is a high risk cardiac procedure. The course of the catheter inserted via femoral artery, then advance retrograde through the iliac artery into the abdominal aorta and into the thoracic aorta. You should be knowing that the tip of the catheter should be in the descending portion of the thoracic aorta, but should be distal to the subclavian artery origin. Okay, usually at the level of T2, T3 on the chest radiograph. So what happens? It is malposition. If it is high up, then this is the tip of the catheter. If it is high up, then it will cause occlusion or maybe some reduction of the blood flow through carotid arteries or subclavian arteries. If it is too low, then it might block mesenteric arteries or renal arteries that will lead to bowel ischemia or renal infarction. If it is incorrectly positioned, then there will be a reduced effectiveness of the hemodynamic support. So this is how the IABP catheter looks like on diastole and systole. So on systole, because since there is a already pumping by the heart, so it will not balloon up. Okay, so the balloon will not get inflated, so that the systolic pressure of the heart, due to the systolic pressure of the heart, the blood is allowed to move distally and freely around the catheter. Okay, like this. When there is a diastole, that means the heart is, there is, because of the poor contractility of heart, there will not be good diastolic flow into the aorta. So that is the reason the balloon gets inflated, and it will cause positive pressure, causing distal movement of the blood, so from the thoracic aorta into the descending thoracic aorta, abdominal aorta, causing good perfusion of the abdominal organs. This is how the IBP catheter works, and this is how it looks like on chest radiograph. So this is the only radio opaque line you will see. If you see such a radio opaque line in the proximal portion of the descending thoracic aorta, then you have to say that this is the IBP catheter. Now coming to the next part, which is a pacemaker. So dual lead pacemaker is the most commonly used pacemaker nowadays. It is, the uses are to treat symptomatic bradycardia, also in cases of heart blocks or arrhythmias, in sick sinus syndrome for cardiac resynchronization in selected heart failure patients. What is the course of the catheter? Course of the lead. So it is usually inserted via subclavian or cephalic vein. Then the leads are passed to the through the superior vena cava into the right atrium and then into the right ventricle. So one of the lead will go into right atrium, the another lead will go into the right ventricle. If there is a third lead or extra lead, that will go into the coronary sinus for left ventricular pacing. What is the ideal tip position? Like we discussed, one of the lead will go into the right ventricular apex or interventricular septum. The atrial lead will go into right atrial appendage. And if there is any third lead for the LV pacing, that will go into the coronary sinus. What if it is malposition? So this particular X-ray was asked in the examination before, in the shorts part, where the diagnosis was Twiddler syndrome, where you will see some coiling of the heart leads. You might get similar X-ray in shots where you will see some break in the leads, or there are excessive tortuous loops of these cardiac leads. Then you have to label it as a Twiddler syndrome. So if it is malposition, then there will be ineffective pacing or failure to capture. There will be arrhythmias. There will be a risk of perforation of myocardium that will ultimately lead to hemopericardium or pericardial tamponade. If lead is in the wrong chamber or vessel, that will cause complications like thromboembolism. Now, what is implantable loop recorder? So this is the implantable loop recorder, the bluish thing. So there are two lines. One is mid clavicular line, another is left parasternal line. So you have to place the in implantable loop recorder in such a way that it should be in the third to fifth intercostal space, should be obliquely lying. Okay, like this is how it will appear on the chest radiograph. What are the uses? For long term monitoring of heart rhythm, to detect unexplained syncope, it palpitations or suspected arrhythmias. It helps in diagnosing intermittent cardiac events such as atrial fibrillations or some various kinds of arrhythmias. What is the course of the catheter? So there is no catheter involved. It is a small device implanted subcutaneously, usually in the left parasternal location at third or fourth intercostal space. Okay, it is oriented parallel to the sternum for optimum ECG signal detection. What happens if it is malposition? There will be poor signal quality, failure to detect arrhythmias. There will be increased noise or artifacts in the readings. The patient might suffer from discomfort or device migration, rarely difficulty in data interpretation. So for today, we'll finish over here. I think we'll need a couple of more sessions to conduct and finish rest of the cardiovascular related lines and tubes. So see you guys tomorrow. I'll be uploading this session on FRCR Rapid YouTube channel soon, and I'll in the next session we'll discuss remaining cardiovascular related lines and tubes. Thank you guys. Bye.